welcome. Today, I'm introducing Dr. Darren Joseph, for those of you who don't know him. He is an adult pulmonologist and specialist physician. He completed his undergraduate training at the University of Cape Town and later his specialist and subspecialist training at the University of Pretoria. Since completing his specializations, Dr. Joseph has held a joint appointments as a specialist consultant physician in the Department of Internal Medicine at Steve Biko Academic Hospital, as well as a senior lecturer in the Faculty of Health Sciences, University of Pretoria. He co-manages a general medical unit and works in the adult pulmonology and medical critical care units. He is extensively involved in student, registrar, and fellow training and has several publications in the field of general medicine and pulmonology. He also works as a private pulmonologist here at Mediclinic Midstream Hospital. Thank you for coming to present to us.
Thank you. Sometimes I choose talks that assume will be of interest to everybody, but this is one that's probably more of interest to me than anybody else. But it's about the new classification of interstitial lung disease. I think it is important to update it. I think it makes it easier for the general physician really to deal with these diseases, which is why I actually want to talk about it. Nothing much has changed. You'll see that's why I've called it rebranding rather than anything new. It's just they've reordered the way we think about these things to try and make it simpler. So I'm going to try and go through it step by step just to explain it, just to hopefully give some insights as to what they've done and why they've done it. So we'll try and answer these questions. Why do we, in the first place, need a new classification? I gave this talk to the registrars and I went back and sort of tried to discuss what is an interstitial lung disease anyway, because I think most people struggle with that concept. And then with all of these new ideas in mind, what should you do when you see one? So interstitial lung disease, we know, is an umbrella term. It's a big group of diseases. There are about 200 according to this guideline now that they've tried to incorporate in some way into the structure. And in some way they involve the interstitium, but they often involve the small airways and the alveoli as well. But you can see trying to put so many diseases into a classification that suits all of them is actually very difficult. So they are rare if you look at them as an individual entity, but if you put them together, they're actually a very common group of diseases. We do see them very often. And the reason they're put together is because they share in some way either a clinical, physiological, radiological, pathological, in some cases therapeutic similarity. And that's why they're put together. But even though they might share those similarities, in other ways they often differ from each other a lot. So they're quite heterogeneous. And so they do have interstitial origins, but they are very seldom pure interstitial diseases. And that's also what makes them difficult to classify, that they might have pleural involvement, airway involvement, parenchymal involvement. And so some people use this term diffuse parenchymal lung disease, which is maybe a better all-encompassing term, but the literature still talks about interstitial lung disease. So we'll stick to that term for now. So you do need some basic knowledge to understand what these things are. So I like to show this image. I think if anyone's ever renovated or built something, you'll know that you can't just pour a concrete slab, it'll crack and break. You have to have something that supports it. And so that steel structure that supports everything that's attached to it is pretty much what the interstitium does for your body, not just the lung. It's basically a structure that holds everything in place and provides support. And it's made up of various things, including the alveolar epithelium itself, and the capillary endothelium itself is also part of that supporting structure. So if you zoom right in at the part of the lung where gas exchange takes place, you'll see that there's a very thin barrier here, almost nothing between the capillary and the alveolus. So there's not really much interstitium there, but every capillary has a gas exchange surface or area and another area where there's an interstitial component. So if you have pulmonary edema, for example, the pulmonary edema, the interstitial fluid will accumulate here. So you get all the curly B lines, all those interstitial changes on the X-ray. And gas exchange can quite happily still carry on at that area there. So you don't really become hypoxic. And it's only when the alveoli then fill up with fluid that you then start to decompensate and drop sats. So, it's useful to keep in mind that the interstitium is not a universal, it's not everywhere. There's not much in that area, for example, it's in specific places. So in these areas that should be very thin and allow for effective gas exchange start to become involved, that's when people start to become quite symptomatic. So as we said, there's an interstitial space, there's not much in there, a bit of connective tissue, a few fibroblasts and other cells, immune cells, and a bit of lymphatics. And that area can become infiltrated with cells, it can become infiltrated with more fibrosis and connective tissue, and then it can spill over into both the alveolar space as well as the capillary space, and you can get microthrombi and other things that can involve the capillaries. So then to understand the anatomy a bit better, and this is important later on, you'll see for the radiology that we discussed, we just take it back a little bit. We talk about the airway tree, and it really is like a tree if you flip it around 180 degrees. So what we can get to if we do a bronchoscopy, you go down the trachea and main bronchi and bronchioles, we can get to around about the subsegmental bronchial level. And then after that, the airways become a bit too small for the scope. But there's actually 23 generations. So there's many more generations after that. And the area that we're talking about is the last 7 or 8 generations where there's so-called respiratory zone where gas exchange takes place. That's really where these diseases are found. So if you then go further, you eventually get to something called a lobular bronchiole. We'll talk now about why it's called that. And the terminal bronchioles come off of that. There's about 20 or 30 that will come off each lobular bronchiole. So that structure is what is known as the secondary pulmonary lobule. And if you draw a line around it, you'll see next to it are lots of secondary pulmonary lobules. So if this is now that interpulmonary lobular septa that you saw in the previous slide, all stained nice and black, and you can see how it fits together like a hexagonal sort of pattern around the surface of the lung. And the whole lung is made up of these subunits of secondary pulmonary lobules. And the reason that's important is because you can actually see these things on CT scan. It's what we look for when we're trying to interpret a scan and figure out what type of interstitial process we have. We're looking for these interlobular septa. And so on the left, you can see that's a normal scan. You can almost not even make out that there's septa there. They're very, very thin. And occasionally you can see something that resembles a septa. But then on the right, this is actually a patient with pulmonary edema. You can see how the interstitium has become quite thickened and more apparent. And so on a chest X-ray, you'd see curly B lines. It's these interlobular septa that are now filled with fluid. And the other reason why it's important is because the end result of a lot of these diseases is honeycombing. And this is why we get honeycombing. It's interlobular septa that are thick with a destructive process within that lobule where there's obliteration of everything that was supposed to be in it. So you get these stacks of cyst-like areas with thick walls, and that's why it's called honeycomb. So there's a nice picture of a secondary pulmonary lobule with the so-called interlobular septa. But you also have intralobular septa, which are supporting structures within the lobule. And these interstitiums are very small and fine. You can't actually see that on a scan. So when that is involved, all you see is ground glass. So ground glass on a CT scan usually represents disease activity. It's usually a filling process of the alveolar, but occasionally it can be fibrosis, especially when it's early. And it's difficult to tell. That's why some people who have ground glass infiltrates don't always respond when you treat them, because it actually is this intralobular septa that are involved in the disease. And there's also an interstitium around the vascular structures, which are in the center of the pulmonary lobule. So when I talk about centrilobular nodules, centrilobular emphysema, they're talking about the structures there in the middle of these in the middle of the secondary pulmonary lobules. So all of that together creates this kind of bicycle wheel effect where you have a centrilobular structure where the artery and the bronchus sit, and you've got intralobular septa that radiate out, and you've got the interlobular septa around the whole structure. And that, if you magnify it out, it actually follows all the way through for the whole lung. So you've also got an axial interstitium right around the main bronchi in the center of the lung, and around the edge of the lung and the fissures and around the pleural surface, you've also got interstitium that is also peripheral, similar to how it's arranged in the secondary pulmonary lobule. The problem for us to interpret this is that in the same area, you've also got other structures. So you've got lymphatics and the pulmonary veins. So if you see interlobular septal thickening on a scan, it can be fibrosis, but it can also be fluid, which can be from venous or lymphatic origin, and it can be a cellular infiltrate and there's many different origins of those cells. So what we end up with is you see a pattern, so-called pattern of intraglobular septal thickening or some other form of pattern, but that pattern doesn't always equal the diagnosis. So the important thing is that you have to discuss both pattern and diagnosis. Now, what we get from the clinical laboratory and lung functions and then the x-rays and CT scans is a so-called morphological pattern. And then we try and attribute a diagnosis to that. But the problem is a specific pattern can have many different diagnoses. So a UIP pattern, for example, could have many different causes. The other problem is that even if you have a very likely diagnosis, so for example, you've got a classic morphological pattern with a clear association, like systemic sclerosis giving NSIP, there can still be other reasons why that person with this systemic sclerosis got an NSIP pattern. It's not one equals the other. And the other confusing thing is that even if your pattern is really indeterminate, you cannot make a diagnosis from what you see, there can still be a definitive diagnosis for that indeterminate pattern if you do further testing, including biopsy. So the pattern that you see is not always the same as the diagnosis that you ultimately make. And then that's what makes this terminology really confusing, because you get a name for the pattern with a similar or sometimes different name for the disease that's responsible for that pattern. So for example, UIP, if it was idiopathic, you would call it IPF. If it had a secondary association, then it would be a UIP pattern with an associated cause, whatever that might be. If it's organizing pneumonia and you didn't have a cause for it, you would call it a COP, cryptogenic organizing pneumonia. If you had a cause, you give it a different name according to what was causing it. So the pattern and the disease differ. And sometimes it's quite difficult when people read around these diseases to know, are we talking about a disease or are we talking about what you're seeing on imaging or on histology? So this is where we are at now with the updated classification. That is part of the problem with the old classifications. And we'll discuss what was wrong with ones we've been using until now a bit as well. So we actually haven't had a classification really for that long. There was one that was formed in 1969, but it wasn't really that user-friendly. And so it's only really in 2002 that they started on this initial classification for diffuse lung disease. Really what they did is they made 4 groups. They focused mainly on the idiopathic interstitial pneumonias. And essentially what they did is they said it's IPF and non-IPF. So that was kind of what you were dealing with, was 2 entities at the end of the day. Then in 2013, they expanded on it a little bit. They included PPFE, which was a new type that was added to it. But other than that, besides expanding on each entity, they didn't add much to the classification. And it was still really dominated by these idiopathic interstitial pneumonias. So there you can see they're divided into 4 groups. So the so-called idiopathic interstitial pneumonias here, they had the interstitial diseases of known cause separate to it. And then they had a granulomatous group and then a group called other, where they just lumped anything they couldn't classify, got lumped in a group called other. Now, the problem is they considered idiopathic and diseases of known causes separately, even though diseases of a known cause can cause the exact same pattern, morphological pattern that we spoke about as the idiopathic group. And then some diseases within the idiopathic group actually had secondary causes, like this group here, which was smoking related. So it didn't make sense to put that in the idiopathic group because it's actually got known causes. And the problem is that this other group is massive. There are hundreds of diseases that fall into that group, which are then unclassified, and so it's an unhelpful, group. So the other thing that they did, so these are some of the important ones that were left off. The other thing that they did is that they sort of divided up into major and minor groups, and the minor being more rare interstitial lung diseases. And the major were then categorized if they were chronic fibrosing, acute, and smoking related. So it was a little bit more helpful, but didn't add much. And the biggest issue for me is that you're left with this alphabet soup of diseases. You got all these letters, no one knows what any of them means, no one knows how they're different, how they look, and it becomes very confusing. So I think for the modern physician, you should forget about these names and focus more on the pattern and what then could be behind those patterns. So that's what they've kind of done in this update. So Emmanuel and I were fortunate to be at the ERS when Ms. Ryerson discussed these guidelines. He was the lead author. So we heard what was proposed and the motivation for why they changed all of these things. It's incredible how the minute that something new comes out, there's already criticism of what has been put forward. So there's already a lot of problems with it that were raised. But we'll try and just go through what was done. So it's very much like the South African Respiratory Journal rebranding itself as the African Journal of Critical Care. Not much is different. It's just got a different name and a different look about it. So that's how the new classification looks, which is intimidating when you look at it like that. So we're not going to focus on that. We're going to go through the highlights and just try and explain what they've done. So there's basically four main points. The first is that they've tried to shift away from the idea that these are idiopathic diseases, and they've tried to put a greater emphasis that these have secondary associations, because the issue is that many of these diseases, when you first encounter them, you don't know what's causing them. Maybe you call them idiopathic, but they often don't remain idiopathic. So as you follow the patient up for months or years, sometimes the cause often comes out later on. So they want to emphasize that these often have secondary causes, and you shouldn't stop looking for them because it can come later. As we said, some entities like the smoking-related ILDs actually are secondary anyway, and they've been put in an idiopathic group. And there really isn't a reason to handle these two groups differently. If you've got an idiopathic UIP or a secondary UIP, you're going to treat them essentially the same way. And then there might be some benefit if you identify the secondary association. There'll be benefit to the ILD itself if you address that. So they've put emphasis now on excluding secondary causes, and it's never an endpoint. So as you can see here, they've put secondary on the table ahead of the primary, because they want you to think of secondary causes before you go to calling it idiopathic, which I think is a sensible approach. So those are some of the secondary things that you'll look for. If you get stuck on the CHEST website, there's a questionnaire that you can download, which is like a tick sheet. And it's got quite an extensive history for interstitial lung disease. So if you're not sure what to ask for, it's easy. You just go through those questions and you can tick them off as you go. Then the second thing that they've emphasized is that these interstitial pneumonias are heterogeneous. So they were called interstitial pneumonia because they've got an interstitial component and a pneumonia component, and sometimes they overlap. So interstitial meaning dots and lines, essentially. Okay, so nodules and reticulation. And alveolar patterns being an alveolar filling process usually. So it's like a water balloon. So you see ground glass infiltrates on CT scans and chest x-rays. So they then divided them up. Instead of calling them interstitial pneumonias, they said, well, some of these are predominantly interstitial disorders and some are more alveolar filling disorders, which I think is easier for the clinician to now differentiate between the two. And there are three main interstitial patterns. There's the UIP pattern, which I think we know. It's a classic, basal peripheral honeycombing picture with traction bronchiectasis. The NSIP pattern, which is non-specific. It's the NS from NSIP, so it is quite non-specific, also in imaging. And then they've got this new term, which is actually, they've brought back an old term, which is bronchiolocentric interstitial pneumonia, which is quite a useful term to use because a lot of these diseases, if you remember the bicycle wheel with the central point, a lot of these are airway-centered diseases, so they're centrilobular. So you can imagine if they affect that centrilobular structure where there's a small airway and an arteriole, that it often gives to mosaic attenuation on a CT scan. It's like an air trapping appearance where you have a mosaic perfusion defect where the artery becomes involved. And so that pattern itself we often see, and it has a group of diseases that are associated with it, especially the hypersensitivity pneumonitis, which is a major differential for all interstitial lung diseases.
It's not the same as boop.
No. But the old boop would have fallen into that pattern. So those are the main interstitial patterns. Then the alveolar filling disorders are really divided up into the more common ones and the more rare ones. but I'll tell you an easier way to remember those. So they've still kept the third group as other, but it's a little bit better defined. So other now is either a combined pattern, and the combination can be a combination of more than one interstitial lung disease. So classically, UIP and PPFE occur together, for example. So that would be in a group 3. But you can also have a combination of an ILD with a non-ILD. And what we see quite often is CPFE. So these are smokers who've got emphysema and then later on develop the UIP pattern or IPF. And so they've got this combination of emphysema and fibrosis. So in order to make a diagnosis, even a provisional diagnosis, you have to have more than 50% certainty that of what you've got in front of you is what you think it is. So if you can't be sure that if it's a coin toss between that disease or that disease, or you really just can't make any diagnosis, you would call it unclassifiable. So you can only really be certain of a confident diagnosis if your threshold is more than 90%. So the vast majority actually of our patients will be given a provisional diagnosis where we strongly suspect that this is what the diagnosis is, but we don't have diagnostic certainty. And the reason for that is we still really don't have any real diagnostic tests for the majority of these diseases that can really be certain of what you see. So the luxury that we have now is a follow-up. As a registrar and fellow, you often don't have that luxury. You see a patient and you may have to make a diagnosis, but now the benefit that we have is that we can follow up patients, and over time we can actually then really be more certain. So pulmonologists, we like to dwell in the realm of uncertainty. So you can see here's the table again. So secondary causes given priority, and then you have interstitial patterns, alveolar patterns, and the combined and unclassifiable patterns there at the bottom. So it becomes easier if you start breaking the whole thing down. So then within each of these disorders, there's further subcategorization. So you've got these 3 fibrotic patterns, and there's a couple of non-fibrotic patterns which are less common. And then in the alveolar area, you've got these filling disorders, and really they're categorized according to what is filling, which this is going right back to medical school now. Fluid or cells, and if it's fluid, the different types will give you different diseases, the cells will give you different diseases. So I don't think you need to learn this table off by heart, but if you think about it like this, it becomes a lot simpler. And that's essentially then what you're left with, is this big table, but it's a much more logical, user-friendly, and all-encompassing group of diseases now. So the third thing is that they have changed some names. So they've included now this bronchiole-centric interstitial pneumonia, which we discussed. So for example, if you had previously a so-called cryptogenic or antigen-negative HP, you would now call that idiopathic bronchiole-centric interstitial pneumonia, which is probably a better term because you don't know for certain it's HP, it could be something else. So you'd rather label it as the pattern. Then this entity, acute interstitial pneumonia, has now changed its name to idiopathic diffuse alveolar damage. So it's essentially ARDS without a clear cause for it. And the reason for that is because other interstitial pneumonias could also present acutely. So there was a little bit of a misnomer there. And most forms of an acute exacerbation are characterized by a diffuse alveolar damage pattern. So they rather went and got the morphology and the pattern more in line with what the disease is. And then the disclamative interstitial pneumonia, which is a smoking-related interstitial lung disease, has now become alveolar macrophage pneumonia because it isn't actually a disclamative process. It's more of an alveolar macrophage filling process. So it's more in line now with what the actual pathology is. So those are the new terms, and that's really all that they've added. The final thing is that they emphasize here again that the diagnosis is obviously important, but what is often more important is the disease behavior. So for an example, progressive pulmonary fibrosis is a progressive fibrotic disease process. Now, if you have a disease that is progressing, that is often more important than what the actual disease is, because there's treatment for that group of diseases. So this is how it's changed. You've gone from a very sort of minimalist, simple classification in 2002 to what looks like a much more sort of bigger classification in 2024, 2025 actually. The reality is that nothing has actually changed between these 3. It's just a much more comprehensive and user-friendly grouping of diseases. So I think it may actually, if you understand the classification, it will make life a little bit easier for most clinicians. The problem is that there is still a lot they haven't covered. So we still don't know really where these diseases fit in, because they can also present very similarly sometimes. So the bronchiolitides can look like BIP, for example, inhalational injuries, histocytic disorders. These things can look like interstitial lung diseases. We don't know where to put them actually in this new classification. So basic approach to diagnosis now, knowing all of that. So essentially, there isn't a pathognomonic test. So we're always working with the most likely. So it starts with clinical suspicion and a hunt for secondary causes, and that's where that tick list often helps. But this is really vital. So, you have to unfortunately go back to this every time. If you have an idiopathic condition, you have to go back to the hunt for secondary causes again and again till it, becomes apparent. So the example that someone previously used at a conference, it was an American pulmonologist who had an idiopathic interstitial lung disease. And because of COVID, they did these telemedicine conferences where they interviewed people online. And while he was talking to his patient, parrot flew in and landed on the patient's shoulder. So she had consistently denied that she had any exposure to birds, and the bird exposed himself in the interview. So then the diagnosis became certain diagnosis of HP. So you have to go back, because sometimes it's not apparent until things drop into place later on. Once you know that you're dealing with interstitial lung disease, you then have to go to radiology. And radiology really requires a CT scan. I'll show you why in a second. But you divide it up into interstitial and alveolar groups, and I think that is really adequate for most non-pulmonologists. If you can at least just separate it out into interstitial and alveolar, it gives you a way forward. And then our job is to try and further subcategorize it. And then you combine all of that with what you get from the lab, your lung functions, in some cases biopsy. And then ideally, you want to have a multidisciplinary discussion about it. We don't always have that available. Fortunately, here at Midstream, we do. At Steve Biko, we do. So we try and, in these difficult cases, have a discussion as a team, and then agree on what we think is likely the diagnosis. So I think we rely on chest x-rays for many things, and they're very useful for many things. But when it comes to interstitial lung disease, they really aren't helpful. And this, I think, shows you why. These are three almost identical x-rays, but they're totally different in terms of what the diagnosis is. So one is a fibrotic process, the other one's lymphangitis, and the third one is cardiac failure. So three totally separate, totally different diseases, but with very, very similar imaging. So really what we want is a CT scan. We want high res because they give very thin slices, so we can see things in much greater detail, and we don't skip layers along the way where pathology might be hiding. We use an inspiratory and an expiratory view. And now with this new classification of bronchiolicentric disease being included, the expiratory view in particular is very helpful, because that's where you see central lobular disease often. And if you see dependent changes, sometimes we even do prone views where you turn the patient over and scan them to see if those dependent changes change according to the patient's position. And really, you just have to think about three things. So first of all, what is the pattern? So for example, is it more reticular, interstitial, or alveolar? Where there's a filling process. What is the distribution? Is it more lower zone or upper zone? And then what are the distinguishing features that can help you really narrow the diagnosis down? So here, for example, is mosaic attenuation, where you have areas of more ground glass and areas where it's more lucent. And this would be an example of subpleural sparing, where you can see it's almost like someone took a black pen around the lung and spared that part of the subpleural area. This is NSRP, where you have subpleural sparing. So, you first wanted to say, well, what is the dominant pattern? Where is it? And then can I see something that really makes it stand out to me as to what this is likely to be? I think that's really the way to keep it simple. So the question that we often struggle with is, should I biopsy a patient? And that really can be quite a difficult decision to make. It really comes down to how much diagnostic certainty you have and the circumstances of the patient. So you go through that same diagnostic process, and at the end of it, you have to decide, preferably as a team, are you really sure what this is? Do you have enough information to go on to at least start treatment, or should you do something more first before treating the patient? So we know if you've got a radiological picture of UIP, a biopsy is unlikely to be helpful. So we definitely don't biopsy those patients. If you've got a clear secondary association and you've got a pattern that fits that association, then we usually don't biopsy. But for the rest, we would at least consider it. And we think about what would be the added benefit, what does the patient want, are they fit for surgery, the risk of the operation, etc. Unfortunately, bronchoscopy is usually not good enough, except maybe for these BIP patients now. But the problem is that when you've seen how far the bronchoscope can go, so unless you can get far enough, if the disease is sort of proximal enough and around the bronchus, you can't really get decent samples of a transbronchial biopsy. So it's something like sarcoid, HP, there sometimes a transbronchial biopsy is useful. But for the rest, you really need either a VATS or an open lung biopsy to get a decent sample. And unfortunately, even with pathology, sometimes it can be non-diagnostic. And sometimes it is totally different histologically for what you see on CT scan. So you have a scan that looks like NSIP, and then the pathologist tells you it's a UIP. And then you struggle now, which one do you go with? So we've said this already, but making a confident diagnosis, it requires a more than 90% certainty. So we are mostly here, a 50 to 90% area with a provisional diagnosis. So they suggest in the guideline now ways that you should report the diagnosis. And really it's the pattern and the diagnosis. So we'd say that the patient has, for example, a BIP pattern, and this would favor a diagnosis of HP. Whereas before we would have said typical HP, that we would have given you a diagnosis. It's a much more all-encompassing diagnosis now. For example, a patient would have a typical UIP pattern, which favors a diagnosis of IPF, whereas before we would have said the patient has IPF. So the terminology and the description changes a little bit to make it a bit more all-encompassing. And this, they're also hoping will assist them with research, because they can then divide up patients with different patterns and diagnoses more easily. At the end of the guideline, and I think this is really useful, there's a whole lot of supplemental information where they, but each group, they give you a nice table of clinical features, radiological features, pathological features with really nice imaging of both the histology and the CT scan imaging. So each of these, there's quite a lot of information dedicated to them. So I think is a nice summary for all of these diseases. They've done that quite well. And then just to mention a little bit on management, which isn't covered in this classification guideline, but really it still depends on three things. So what do you think the diagnosis is, because there may be something specific that you have to manage there. The balance between how much inflammation and fibrosis you think is present and the disease behavior itself. And often that's the most important. So if it's not progressive, you might be more conservative. So you're kind of looking at this. Diseases are often mixed. There's often an inflammatory and a fibrotic component. But the more inflammatory it is, the more likely it is to respond to immunomodulatory therapies. There's a whole host of them. And the hope is that you can get complete resolution if you treat it at this stage. The further along you get to fibrosis, the less likely these therapies are going to work, and more likely you're going to have to then just use antifibrotics. But for me, at least, these antifibrotics is like you give it with a very heavy heart, because it means you've missed the boat and you actually can't do much for the patient anymore. These drugs don't reverse the fibrosis, they just slow it down. In my experience, which is, I would admit, is quite limited, but I haven't really seen a great effect with these antifibrotics treating these progressively fibrosing disease patients. They don't have a huge impact. So the important thing as well is that you have to review the response to therapy and adjust accordingly. So, if you decide to give an immunomodulatory drug and it's having no effect, you may be exposing them to cost and risk without much benefit. So you need to go back and reevaluate. There's still a lot of problems, a lot of controversies. As we said, there are all those entities which they still haven't included formally in the classification. They haven't really discussed what to do with IPAF. They mention it, but they haven't really done much with it yet. It's still not its own entity and hasn't been refined much. This concept of progressive pulmonary fibrosis is mentioned again as a phenotype of fibrotic lung disease, but again, they haven't defined what progression is. So how much fibrosis do you need to progress by? How much further decline in lung function do you need? None of this is agreed on. The disease behavior is not part of the classification. So, for example, you've got the fibrotic interstitial lung diseases, but they could divide that up into non-progressive and progressive, because that'll help manage those patients better. That hasn't been taken into account. There's no accounting for changing morphology. So, for example, some people begin as a more sort of cellular alveolar appearance, morphological pattern, and then progress to a fibrotic pattern. So there's no accounting for that in the classification. The other problem is that if you're classifying these patients according to morphology to try and get closer to a diagnosis, but often the different ways that we interrogate morphology differ from each other. So the pathology and the radiology might look completely different, give you a different diagnosis. And what do you do with that? Where do you assign them in the entity? The concept is that you should use dominant pathology if you've got a combined pattern, or if you've got the synchronous characterization of morphology. You should go for what's dominant. But again, they haven't told you how you determine what is dominant. So how do you know which one is more significant than the other? So there's a lot of unanswered questions. So Professor Kerr said to me, every time a group of specialists get bored and have run out of things to publish, they decide to look at the classification. And so maybe there's some of that going on here. I do think there's benefit to what they've done, but there's still a lot of you need to go through, and a lot that we still have to consider for future classification. So really, in summary, these diseases are actually quite common if you start looking at them all together. And you see them weekly, new patients with these diseases. The classifications are really still a work in progress, and that is a problem for the general physician and general practitioner, because you see these patients first and have to refer them, but there's a very poor understanding and a very poor knowledge of how to approach these patients. And it doesn't make it easier when the classification systems aren't user-friendly and aren't helpful. So hopefully this is going to make that a bit better, but there's still a long way to go. Really, I think the clinician's role, the general clinician, is to just identify first that this is a possible interstitial lung disease. And if you can at least identify what the main pattern of disease is interstitial, alveolar, fibrotic, non-fibrotic, that'll help you to start the process. And then you can take it further, but it at least gets you the ball rolling in the right direction. Exclusion of secondary causes is really vital. And remember to revisit that. A confident diagnosis is not, unfortunately, the norm. We're usually dealing with what is a provisional diagnosis. And because of that, the team approach is really preferred if you can set that up. And then certain diseases have specific management approaches where you say, well, if you've got this, you should preferably give that form of therapy. But very often, we don't know exactly what we're dealing with, and the therapy is not specific for the disease. So then we have to go with what we think will work the best. And very often what informs that decision is how the disease behaves. So it's the power of follow-up, the power of experience sometimes. And then once you decide on an approach, review the patient and see whether they're actually responding to what you're doing. And I think that is it.
I think we use the KL6. Yeah.
So if you go to that guideline, there's a chapter in there on all these new biomarkers. None of them have got mainstream use yet, but there's a whole chapter on that and many others. There's tons of biomarkers that they're looking at. It summarizes where they're at with all of them well, but none of them are useful in clinical practice.
You say antifibrotics. Okay.
I think there's a place for it when people have really hit their end stage disease. But the reality is you yourself have kind of failed the patient by that point, because you're telling them, I've got nothing to give you. So all I can do now is try and put the brakes on this disease. Often it helps, but it's not the holy grail, unfortunately. So what was interesting is we're still at the point where we have to try and fight for antifibrotics for our patients. In Europe, they're now combining antifibrotics. So we have treatment failure on one, they now combine them. So we'd be far away from that here. To get one is often a struggle. But that just shows you how they when you start talking about having to combine these drugs, it tells you they're probably not working as well as you would like them to.
What's your favorite drug? Oh, sorry. No. What's your favorite drug? Reducing inflammation.
Now look, it's different. It's difficult. So
Maybe similar to yours.
yeah, it really depends on what you are treating. So where the evidence lies, I think there's a place for steroids still, rather than going for these big immunomodulatory drugs. But the biologics are really good, but as you know, to use them first line,
Which one?
well, it depends on the disease.
Let's just say, for instance, it's NSIP.
Again, NSIPs are it's non-specific, right?
Yeah.
Lots of causes. But if you're talking rheumatologic diseases, often go rituximab, for example, but it's not the only option out there. It really depends on what the secondary cause is likely to be. But if you worry that this is an inflammatory disease, then you're targeting the whole inflammatory cascade. So it depends what you think is the dominant.
What's your experience been so far with cell sickness?
For interstitial disease? Yeah, it's effective. So we've seen people that respond well to it, but there is a subset of people who really just don't respond to it. And that's a problem because are they not responding because the drug's not working, or they're not responding because you've got the diagnosis wrong? So we do switch, often then to a biological, and sometimes we see a response after that. But sometimes we consider in those patients actually going for biopsy and seeing what's going on there, because sometimes what you've done is you've mistaken the intralobular septal thickening, which we said can look like ground glass. You've mistaken that for activity, and actually it's a fibrotic process that they're not going to respond. And so the biopsy can help you with that.
I think our problem is once patient gets to the point where they need a lung biopsy, they're so ill that they actually are not fit for a lung biopsy.
That's right.
And then you decide, well, is it really worthwhile putting the patient on a ventilator? Probably not getting the patient off a ventilator.
Yeah. So that is often the problem. That by the time they get to the point of being worked out for biopsy, it's often very late.
Yeah.
Which is the whole emphasis of this, is get people to the right people early. But whatever the case may be, they often do come too late, and they often are too sick to biopsy. So then the decision really is, well, okay, you've got this disease, you can't get histology, and the patient's really ill. So perhaps a trial of therapy is appropriate, but you also run the risk of decompensating them further by giving them therapy. So it becomes what is the most likely benefit for this patient, and that's where having someone to bounce an idea off, saying, Manuel and I talk often, should we treat this patient or not? Because it becomes difficult. You can decompensate them further, or you can really benefit them. Often we give the patient the benefit of the doubt, because if you don't treat, you know where it's going. So you give a trial of therapy, and there's been some amazing success stories with that.
And the question is lung function. Does lung function also guide you towards a direction, which will make it more likely?
So lung function, there are obviously characteristic features on lung function for different diseases. But the main thing is to track progress over time, especially when you're talking about these progressive diseases. The problem is there's no agreed definition of how much of a decline in lung function is significant for progression. So we use 10% as a rough number. If the value is decreased by 10%, some parameters 15%, but that is a thumb suck at the moment, it's the best guess. So that's where it's more useful. The lung functions are never diagnostic for anything. There's nothing that you can look at a lung function and go, it's this. So we use it to track progression and define severity. Even COPD, I give a COPD lecture to the students. I tell them the lung function is a waste of time in South Africa, because most people are working in places where there isn't a lung function available. Now you have a disease where the treatment is decided on lung function, the diagnosis is made by spirometry, but you don't have one.
Mm.
So you actually need to stop thinking about lung functions as the be all and end all of medicine and start using clinical judgment.
Thank you.
Thank you.
Thank you very much, Darren. I don't recall anyone teaching me this when I was a registrar. I feel like opening like Harrison's and trying to decipher what's going on. So
I remember that too.
I actually don't. So I mean, obviously, admittedly, we don't need to know it in like the depths of a pulmonologist, but I mean, an understanding is often better because otherwise you're just in the dark.
Exactly.
Completely. Okay. Thank you very much. Thank you for the people online. Have a good week.